بسم الله الرحمن الرحيم. أبنائي وبناتي من طلبة المرحلة الثانية كلية الطب جامعة الموصل، السلام عليكم ورحمة الله وبركاته. Today we have lecture 2 in specialized embryology of gastrointestinal system. Look at this picture. Here is an infant with history of projectile vomiting. I mean sudden vomiting. That's due to congenital abnormality in the foregut of his GIT. Let's remember, the primitive gut is formed during the week 4 of gestation, where the flattened embryonic disc falls into two planes, median and horizontal, so forming a tubular structure, which is derived from the dorsal part of the yolk sac, which is incorporated into the body of the embryo, forming the primitive gut. So we have two ventral folding to form the midgut, and two ventral folding cranially and caudally to forming the foregut and midgut. This is the primitive gut, whereas there is the foregut and midgut and hindgut. Foregut. What are the parts of the foregut? The foregut gives off into the following: pharynx, lower respiratory system, esophagus, and stomach, and the proximal part of the duodenum with liver and biliary trees and pancreas. What are the steps of the embryologic development of the stomach? Look at this is stomach, the greater curvature and lesser curvature, cardiac end and pyloric end, ventral view of the stomach. At week 4, stomach appears as spindle-shaped dilation of the foregut, caudal to the esophagus, attached ventrally by ventral mesogastrium and dorsally by dorsal mesogastrium. So this is the stomach spindle-shaped dilatation, caudal to the esophagus, and inside the ventral mesogastrium, the liver bud grow. So dividing the ventral mesogastrium into the lesser omentum between the porta hepatis of the liver and the lesser curvature of the stomach, and the falciform and coronary ligament, which connects the liver to the inner surface of anterior abdominal wall and to the umbilicus. While the developing spleen dividing the dorsal mesogastrium into gastrosplenic ligament and lienorenal ligament. Here is the stomach, and here is the spleen, and here is the liver. Subsequently, stomach appearance and position drastically changes. The latter can be better understood by visualizing the longitudinal axis and antero-posterior axis of the stomach. So the stomach not remain as spindle dilatation. It undergoes several rotations, two rotations on its longitudinal axis and antero-posterior axis. What are the axes of the stomach? We have longitudinal axis and antero-posterior axis. Besides that, stomach descends due to the rapid elongation of the esophagus, and the cardiac region descends from C2 at week 4 to T12 at week 12. The cardiac end descends from C2 at week 4 to T11 at week 12. Then, after enlargement of the stomach, it slowly rotates at 90 degrees. Rotations of the stomach. Stomach differentiate more and more, so It has fundus, greater and lesser curvature, which are become very clear. And now the lesser curvature faces ventrally, while the greater curvature faces dorsally. The first rotation of stomach. The stomach rotates 90-degree clockwise rotation around its longitudinal axis from left to right. Thus, the lesser curvature faces to the right, while the greater one faces to the left. So, here is the longitudinal rotation of the stomach involving 90-degree clockwise rotation. So, the right side of the stomach facing posteriorly and the left side of the stomach facing anteriorly. So, the stomach left side facing anteriorly and the right side of the stomach facing posteriorly. So, the left vagus that innervates the anterior wall of the stomach, it's once innervated the left side of the stomach, whereas the right vagus innervates the posterior wall and it once innervated the right side. So the left vagus become innervation to the anterior wall, while the right vagus innervates the posterior wall of the stomach. Here is both vagi of the stomach. The left one becomes anterior, while the right one becomes posterior. Concurrent with this rotation, the cellular proliferation occurs much faster in the posterior wall of the stomach than the anterior wall of the stomach, resulting in the formation of greater curvature and lesser curvature, respectively. What is the steps for the second rotation? The stomach rotates around its antero-posterior axis, resulting in the caudal end, which is the pyloric part, moving upward and to the right, while the cranial part or cardiac end slightly moving downward and to the left. So the stomach assumes its final position, where is the pylorus located superiorly and to the left, while the cardia facing inferiorly and to the right. What about the mesenteries? The rotational changes of the stomach also alter the position of mesenteries. Remember that the stomach is attached to the ventral mesogastrium and to the dorsal mesogastrium, respectively. The rotation of the stomach surrounding its longitudinal axis, pulling the dorsal mesogastrium to the left and the ventral mesogastrium to the right. So here is the dorsal mesogastrium and here is the ventral mesogastrium. So pulling of the dorsal mesogastrium to the left and the ventral mesogastrium to the right. So we have a space here called the omental bursa or the lesser peritoneal sac, which formed behind the stomach. Again, during the rotation or throughout the rotation of the stomach around its longitudinal axis, there is a pulling of the mesogastrium toward the left and the ventral one to the right. So, creation of the space called omental bursa behind the stomach. This is the ventral view of the lesser sac which lies behind the stomach. The lesser sac anatomically communicates with the general peritoneal cavity through a foramen called epiploic foramen. What about the congenital anomalies of the stomach? Several congenital anomalies of the stomach may happen. Number 1, congenital hypertrophic pyloric stenosis. Number 2, changes in the shape or shapes of the stomach. Number 3, variation of the origin of the blood vessels. Number 4, duplication of the stomach. And number 5, abnormal shape prepyloric septum. And number 6, malrotation of the stomach. Here is an example of one of the congenital anomalies of the stomach, which called congenital hypertrophic pyloric stenosis. We have hypertrophy either in the inner circular or outer longitudinal muscle of the pyloric region. It is one of the common anomalies in the newborn, clinically characterized by sudden vomiting or projectile vomiting, and it's treated by surgical excision of area of hypertrophy. Here is a picture of the congenital hypertrophic pyloric stenosis, and here is the picture of normal pyloric region of the stomach ventral view. In this picture, we have double pyloric region or double pylorus, while here is a presence of abnormal area of pyloric region making a shape of hammer like shape stomach. Thank you for your listening.